You know the old saying, nothing in life is certain except for death and taxes. If there's one thing that we know, everything that lives dies. We, as human beings, as creatures capable of conscious thought, can choose how we die, at least to some degree. We can choose what happens after we die as well. We have many choices in preparing for the end of our lives. In preparing for our end-of-life care, there are a couple things to take note of. Do you have a living will or an advance directive? Have you considered hospice care or other treatment options? Do you want to be an organ donor? Doctors today are listening and communicating with patients better than in the past. Doctors are more likely to listen to the concerns and wishes of their patients where death is concerned. It is important to have honest and open dialogue with your doctors as well as your families, but first we need to consider what our feelings and wishes are. Considering your own death is often difficult and can produce anxiety. Studies consistently find a low to moderate level of death anxiety, but this can be overcome with accurate information and open discussion. This discussion can help us determine what we want to happen at our end of life. An advance directive or living will is our first step. Advance directives are legal documents that allow you to dictate your decisions about end-of-life care while you are still alive. There are many options and formats available via the internet, your physician's office, or the hospital. Advance directives allow you to communicate your wishes to family, friends, and healthcare professionals to avoid confusion later. This can be incredibly valuable in emergency situations. A living will is a document that allows you to instruct your physicians to administer, withdraw, or withhold artificial life-sustaining treatments in the event that you are diagnosed with a terminal or irreversible condition and are unable to make your own healthcare decisions. It is often used interchangeably with an advance directive. It is common that the hospital staff will ask upon admission if you have either one of these in place. If you do not, they can also offer you the chance to complete one. I have provided a couple of websites, caringinfo.org and the Mayo Clinic, that can provide you information and guidance on living wills and advance directives. It also includes a simple one-page advance directive sample. Once again, having a frank and open discussion with your loved ones about CPR, life support, feeding tubes, and pain management can be a source of anxiety, but it can also save a great deal of time and stress in the long run. Medical treatment at the end of life can be scary. There are many things to consider. With today's medical advances, we can live longer after a diagnosis of a serious illness. According to Dr. and author Atul Gawande, the pattern of health decline has changed for many conditions such as liver disease, congestive heart failure, or emphysema. Medical treatments can stretch out our decline to help us live longer with the illness. In the past, a medical condition could have a rapid onset and a fast decline towards death. Today, that same condition could be managed with proper medical treatments for years, with a much slower progression towards death. As patients, we have a choice to accept or decline these treatments. We can allow the condition to progress naturally or undergo treatment to prolong life. We can opt for painful surgeries or chemotherapy, or we can choose to forego treatments and allow the condition of the disease to progress naturally towards death. Once curing the condition is deemed impossible, patients can choose to enter hospice care. According to Dr. William Shiel, hospice is more than just treatment. It is a philosophy of care. It is the idea that when you or someone you love has an illness that can no longer be cured or treated, there is still something that medical professionals can do to make patients as comfortable and pain-free as possible. Hospice is provided at the place of the patient or family's choosing, either at home or in a hospice facility. Hospice care is directed at the entire family, so whenever it is provided, it consists of more than just nursing care and medications for comfort. Spiritual guidance, respite care, and social work are all offered by hospice programs. Hospice is designed to make the transition through illness into death as comfortable as possible for the patient and the family. When death comes, we can then consider other possibilities like organ donation. Organ donation takes healthy organs and tissues from one person for transplant into another. Organs from one donor can help save or benefit up to as many as 50 people. There are a number of organs that can be donated, such as the kidney, heart, the liver, pancreas, intestine, the lungs, skin tissue, bones or bone marrow, even the cornea from your eye. Most organ and tissue donations occur after the donor has died. However, some organs and tissues can be donated while the donor is still alive. According to the American Living Organ Donor Network, in the United States, one person dies almost every hour while waiting for an organ transplant. This number could be less if more people chose organ donation. Suicide is a topic worth considering at end of life. Who is more likely to choose suicide and why? Suicide is defined as the intentional taking of one's own life. Suicide is the 10th leading cause of death overall. It is the 3rd leading cause of death in people 15 to 24 and the 2nd leading cause of death in people 25 to 34. Suicide rates have increased in older adults. Women attempt suicide more often than men, but men are more likely to be successful in their attempts. According to Kastenbaum, the suicide rate is higher in people who suffer from depression, who use drugs or alcohol while suffering from depression, are divorced or have lost important relationships, and people who are suffering from irreversible illness or painful medical ailments. Assisted suicide, also referred to as euthanasia, has been a hot-button issue for the last decade. It is defined as taking deliberate action with the express intention of ending a life to relieve unstoppable suffering. It can be classified into 2 categories, voluntary or involuntary. Voluntary euthanasia is conducted with the consent of the patient. Involuntary euthanasia is made without the consent of the patient. The decision is made by another party because the patient is incapable of action. There are also 2 types of euthanasia, active and passive. Active euthanasia refers to specific actions that are specifically intended to end life, while passive euthanasia is the withholding of any treatment that may prolong life. Euthanasia is controversial, but people tend to be more tolerant of passive euthanasia, as withholding of treatment is often outlined in advance directives and living wills. This is another reason why it is so important to have an advance directive on file with the hospital. Proponents of euthanasia use the term right to die. They believe that people have a right to die how and when they choose. The right to die movement gave way to death with dignity. There are currently 5 states and the District of Columbia that have active death with dignity laws on the books. California, Colorado, Oregon, Vermont, and Washington, along with D.C. These laws allow mentally competent adults that suffer from terminal conditions with 6 months or less to live the right to request and receive lethal medications from their doctors for the purpose of ending their lives. In all cases, the patient must be the one to administer the medication for themselves. If they are unable to do so, then they may not use the medication. On a personal note, I support Death with Dignity acts, but this will remain a very controversial topic going into future decades. Death is the inevitable end of life, but what happens then? There are many options available to us for our final destinations. Burial and cremation are the most popular choices, but I would rather focus on some of the lesser-known options available to us. Body donation is gaining popularity. The University of Tennessee's Body Farm accepts body donations for the study of forensics. They use donations to study body decomposition under various conditions in order to help better determine the time of death. You can watch a video called Corpse Tech that will give information on the University of Tennessee's program. Another body donation option, which may seem a bit extreme, is crash testing. Car manufacturers are often using cadavers in crash tests to help study the damage to the human body that occurs in automobile accidents. There are also other options that are a little less well known. Resumation uses heated water and potassium hydroxide to liquefy the body, leaving only the bones behind. The bones are then pulverized, much as in cremation, and the bone fragments are returned to the family. Eternal reefs are an option provided by the Georgia-based Eternal Reef Society. It creates an artificial reef material out of a mixture of concrete and human remains. These heavy concrete orbs are then placed in areas where reefs need restoration, attracting fish and other organisms that turn the remains into an undersea habitat. Plastination involves preserving the body in a semi-recognizable form. It was invented by anatomist Gunther von Hagens. Plastination is used in medical schools and anatomy labs to preserve organ specimens for education by using chemicals to preserve the body in a plastic-like state. Cremation, invented by Swedish marine biologist Susanne Wright-Massick, submerges the body in liquid nitrogen until it becomes frozen and brittle. The body is then gently shaken apart and rendered into powder, which is then returned to the family. We don't give much thought to our death in our day-to-day lives. As a society, we try to shy away from death. We want to avoid the topic. We don't want to think about what we're going to do when we're terminally ill or what we want to do after we die. Death is a journey. It's very personal. By taking initiative and preparing for our end-of-life care, we can make the journey our own. Thank you for listening today.